Good afternoon, ladies and gentlemen. On behalf of my co-chairperson, I would like to welcome you to the first free paper session of the annual academic sessions of the Galle Medical Association. We have 6 oral presentations for this session, and there will be 8 minutes for each presentation, followed by 2 minutes of discussion. We would like to remind the audience to direct your questions through the Q&A box. We'll move on to the first presentation, and the title is COVID-19 Surveillance During the Early Stages of the Pandemic in the Southern Province, Sri Lanka, authored by Wijayaratna WMDGB, Gunasena S, Nagahawatta ADS, Veerasinghe NP, Tilakaratna LG, Nicholson B, Woods C, Dantanarayana N, Gunasekara N, Dharmasiri GNJ, Mahalyanige DT, Vikramsinghe SS, Sabru HHPMJ, Piyasiri DLB, Priyanti D, Leuke Bandar R, Ubesekara HA, Bodhinayaka CK, Devasiri IV, and Amarasena TSD. The paper will be presented by Wijayaratna WMDGB.
Good afternoon. Our study is on COVID-19 surveillance during the early stages of the pandemic in the southern province, Sri Lanka. COVID-19 RT-PCR testing facility established in the Department of Microbiology, Faculty of Medicine, University of Brunei, to support the National COVID-19 Diagnostic Network of the Ministry of Health since May 2020. By that time, there were few RT-PCR machines available in the country. Therefore, we took the challenge of mobilizing the existing resources to cater the national need. Surveillance testing for COVID-19 infection helps to identify emerging clusters within the country. This study aims to assess the COVID-19 status in the southern province at the initial phase in 2020. This was a prospective observational study conducted among patients attending the outpatient departments of the 3 main hospitals in the southern province: Teaching Hospital Karapitiya, District General Hospital Matara, and District General Hospital Hambantota. Patients' demographic data, relevant clinical information, and exposure to the disease was documented. From all patients, a nasopharyngeal and an oropharyngeal swab was collected and tested for COVID-19 using CDC RT-PCR test kit. Results. This slide shows the epic curve of the COVID-19 patients in Sri Lanka from the beginning to date. And you can see where our study period falls from 19th June to 20th November 2020. That is, it covers the latter part of the first wave and the initial part of the second wave. From the southern province, we have enrolled a total of 859 patients, out of which 44.8% were from Galle, 28.1% from Matara, and 27.1% from Hambantota districts. Of the study sample, 57% were male patients. According to the age distribution, 89.8% of them belongs to the age group of 15 to 59 years. This slide shows the distribution of the occupation. Only 290 patients responded to this question, and out of that, 12.76% were frontline workers involved in combating COVID-19. So they were doctors, nurses, other healthcare workers, and people from armed forces and police. Then here, check the presence of fever, cough, and sore throat as features of ILI or influenza-like symptoms in the study group. From the total study group, 29.4% had at least one feature suggestive of ILI. Regarding the complaining symptoms at the time of the PCR testing, 14.5% had fever, 25.5% had cough, 7.8% had common cold, 24.3% had sore throat, 5.4% had shortness of breath, and 0.8% had diarrhea. None of the surveyed participants has been previously positive for COVID-19. 4 of them has been tested previously for COVID-19, but found to be negative. None of the surveyed participants has been previously admitted to a COVID ward or been quarantined in COVID-19 isolation camp. In the study group, there were 20 people with possible conditions leading to immunosuppression, such as diabetes, renal failure, and those who are on immunosuppression drugs. And there were 2 pregnant mothers in the study group. Then we check the potential exposure to COVID-19 in the study group. In this, 9.4% had exposed to positive patient before treatment. Another 1.4% exposed to positive patient after discharge from the hospital. 1.9% exposed to first-line contact after the period of quarantine. 7% has been exposed to foreigners or from people from overseas returning. Another 7.9% exposed to people from armed forces or police. So, as a whole, from the study group, 9.1% of people had some sort of potential exposure to COVID-19. Then we move to the test results of the COVID-19 RT-PCR. From the study group of 859 tested, only 1 became positive for COVID-19 RT-PCR test. This person was from Madura and had sore throat at the time of testing. He has been exposed to a positive patient while at work in Western Province. He is a worker from the Colombo Harbour. So if you plot our findings in the pickup, you can see our positive finding was towards the end of the study period. It is more informative if you plot the same in the data from the Southern Province. So this slide shows the distribution of confirmed COVID-19 cases reported from the Southern Province. So you can see the first cases from Galle and Mathura district were reported in March 2020, and the numbers remain low until early November. From 14th of November, there's a sudden increase of cases in the Southern Province. So with this increase, the community positive case found in our study. So there's a positive rate in this total study sample of 0.12%, and it is high, 0.39% among those who are having symptoms suggestive of ILI. The overall prevalence of COVID-19 in the community of the Southern Province of Sri Lanka is 0.04 per 100,000 population. Therefore, we'd like to conclude that the prevalence of COVID-19 in the community of Southern Province of Sri Lanka was low, with no evidence of infection among asymptomatic population during the latter half of the year 2020. These were our references, and we would like to acknowledge the administrative support given by Professor Sujiva Amarasena, Vice Chancellor of University of Brunei, Professor Vasantha Devisiri, the Dean Faculty of Medicine, and all officials in the Ministry of Health and staff of Department of Microbiology, Faculty of Medicine, Galle. We would like to also to thank the financial contribution by the National Research Council Rapid Response Grant and the Duke University, USA. Thank you.
Thank you for your presentation. The paper is open for discussion. I would like to remind the audience to direct your questions through the Q&A box.
We'll start. I think time is up. The next presentation is on notified incident cases of dengue and leptospirosis. Time series analysis for two commonest vector-borne diseases in Sri Lanka. Papers by Darshana ILAN, Shamika RMA, and the paper is presented by Darshana ILAN.
I am Dr. Darshana from Department of Community Medicine, Faculty of Medicine, University of Ruhuna. Our study is notified incident cases of dengue and leptospirosis, time series analysis for two commonest vector-borne diseases in Sri Lanka. As you all know, dengue and leptospirosis are considered as the two commonest vector-borne diseases in Sri Lanka, which have high case fatality rate. According to Epidemiology Unit, in 2020, dengue had 0.01% case fatality rate and leptospirosis had 0.43% case fatality rate. In Sri Lanka, we have good disease surveillance system. So under that disease surveillance system, each and every patient treated for leptospirosis and dengue will be notified into Epidemiology Unit using H399 form. Apart from that, due to imports of those two disease conditions, there are a special surveillance system as well as sentinel surveillance for leptospirosis and dengue in Sri Lanka. Now I will explain why we use time series analysis approach in our study. Time series analysis is a specific way of analyzing a sequence of data points collected over an interval of time. In our study, we have used monthly notified incident cases of dengue and leptospirosis for 12 years duration. So we had series of data which have collected through a long time period. So we can use time series analysis approach in our study. By using time series analysis approach, we can ensure any trends or patterns as well as any seasonality in those two selected disease conditions. Apart from that, interestingly, we can use time series analysis approach for the forecasting of those two diseases. That means we can predict future incident cases of dengue and leptospirosis based on the historical data which already have collected. Although there are several approaches in the time series analysis, we use best as well as commonly used method of the ARIMA model in our study for the time series analysis. ARIMA means autoregressive integrated moving average. And when there is a seasonal variations, we can combine ARIMA model with the seasonal component. We call it as the ARIMA model. By forecasting incident cases of dengue and leptospirosis, we can identify the disease outbreak situations in future, as well as we can allocate resources for the curative sector and the preventive sector for the management of the patients, as well as we can plan and implement preventive programs for the dengue as well as leptospirosis. With these justifications, we decided to do a study to develop two separate models in order to forecast of monthly notified incident cases of dengue and leptospirosis in Sri Lanka. So we did the retrospective time series analysis and we collected data through publicly available website of Epidemiology Unit, which were collected through routine disease surveillance system based on H399. Data were collected from 12 years duration, January 2010 to April 2021, and monthly notifiable incident cases of those two diseases were recorded. Data analysis were done using Minitab statistical software. Level of significance was considered as 0.054 residual analysis, and ACCA information criteria was used to select the best fit models to assess model accuracy. So when we did data analysis, first we draw the time series plot to check whether the data is stationary for mean and variance. If the data are not stationary for variance, we did natural log transformation. And to do the data stationary for mean, we did differentiation, and then we draw the correlogram of ACF to check are there any seasonality or not. If the seasonality was identified, we did the seasonal differentiation to remove the seasonality, and then again draw the correlogram of ACF to confirm the stationary of data. After confirming the stationary of data relevant to the variance and mean, we draw the correlograms for the PACF also, and using the correlograms for ACF and PACF, we find the simple PQ values and capital PQ values of the model. Then we did the residual analysis to identify the significant models by checking the autocorrelation, normality, and randomness. And finally, AIC was calculated for the selected significant models to assess the model accuracy, and best fit model was selected according to the lower AIC value. Now I will move on to the results. According to the result, first we try to identify are there any correlation between the reported monthly incident cases of dengue and leptospirosis. However, we got PSNR value as minus 0.04, so we consider it as almost equal to 0, and we concluded that there is no correlation between the reported monthly incident cases of dengue and leptospirosis. However, the direction of the correlation was noted as negative, so we can assume that there is a negative correlation between leptospirosis and dengue monthly incident cases. That means when the leptospirosis cases are increased, dengue cases may be decreased. Then we draw the time series plot for dengue and leptospirosis separately. As you can see in the given slide, you can see most variations in the leptospirosis compared to the dengue. However, according to these two time series plot, we identify both dengue and leptospirosis data were not stationary with respect to mean and variance, and we note a trend and seasonality in the given two data sets. So now I will consider dengue and leptospirosis separately. First, I will consider the dengue. For the dengue, after seasonal differentiation, we draw correlogram for ACF and PACF. Based on these two correlograms, we identify possible values for AR and MA component of the model. Based on these suggested values for AR and MA component of both ARIMA and seasonal component, we identify 11 possible models for dengue. So then we did residual analysis for those 11 models. We did Box-Pierce test to assess the autocorrelation, Anderson-Darling test to assess the normality, and Run test to assess the randomness. By using these three tests, among 11 models, only 2 models were remained significant after residual analysis. So then we calculated AIC for those 2 remaining significant models. Among those 2 models, only ARIMA model 312 with seasonal component 011 was identified as the best fit model for dengue, which have lowest AIC. When consider the leptospirosis, these are the correlograms for ACF and PACF of leptospirosis. Using these 2 correlograms, we identify these suggested values for the AR and MA component of the both regular ARIMA component and the seasonal component. Using these suggested values, we identify these 12 models for the leptospirosis as possible models. However, after the residual analysis, only 3 models remained significant. And then we calculated AIC for those 3 significant models. And among them, ARIMA model 111 with seasonal component 011 was identified as the best fit model for the leptospirosis. Then we did the forecasting. Under the forecasting, seasonal peak in dengue incident cases can be expected in the July 2021, while leptospirosis in the November 2021. So based on these results, we can conclude that identify 2 models can be used to forecast of incident cases and impending outbreaks for dengue and leptospirosis. And these informations can be used for the management of those 2 communicable diseases And this information will be helpful for the healthcare planners of the country for implementing preventive and curative measures for these two deadly diseases. These are the references we have used for our study. And thank you very much for the given opportunity to present our study findings in this forum. Thank you very much.
Thank you very much for your valuable presentation. Now the paper is open for discussion. We have only 15 seconds. There are no questions from the audience. Therefore, we will move to the next paper.
We'll move on to the third presentation for today. The title is Evaluation of a Staining Technique Using Toluidine Blue in Comparison to Gram Stain for Direct Detection of Bacteria in the Positive Blood Culture Broth, authored by Kumara YNB, Vikram Singh SS, and Piris HH. The paper will be presented by Vikram Singh SS.
Evaluation of a staining technique using toluidine blue in comparison to gram stain for direct detection of bacteria in the positive blood culture broth. Early administration of appropriate empirical antibiotic treatment has enhanced the survival of patients with bacteremia. Direct gram stain smear positive blood culture broth is much helpful in the rapid identification of the causative microorganism and determining the empirical antibiotic treatment. The morphology of bacteria may change due to the prior antimicrobial therapy of the patient. The species of gram-negative rods may become filamentous and pleomorphic. Also, bacteria can be easily misidentified because of the similarity of the morphology of the bacteria. No other staining technique has been used as an alternative to gram stain for direct staining of the positive blood cultures. Cheeseborough recommends that bacteria can be easily detectable if the preparation is stained using toluidine blue 0.5 weight volume rather than gram staining technique in a thioglycolate broth culture according to their morphology. The aim of the study was to evaluate a staining technique using toluidine blue in comparison to gram stain for the direct detection of bacteria in positive blood culture broth. Objective was to evaluate the accuracy of a staining technique using toluidine blue in comparison to gram stain for the direct detection of bacteria according to their morphology in the positive blood culture broth by comparing the sensitivity, specificity, positive and negative predictive values of toluidine blue stain with the gram stain. This was a diagnostic cross-sectional study using 155 positive blood culture broths collected from microbiology laboratory in Teaching Hospital, Karapitiya. Direct smears of positive blood culture broths were stained with gram stain and toluidine blue stain. Culture isolates of these blood samples were stained with gram stain and considered as the gold standard. Ethical approval was obtained from the Ethics Review Committee of Faculty of Allied Health Sciences, University of Raghunath. Sensitivity, specificity, positive predictive value, and negative predictive value were calculated using direct smear results of gram stain and toluidine blue stain in comparison to gram stain results of the culture isolates, which was considered as the gold standard. Sensitivity was the proportion of positive test results out of all culture correct results, and specificity, the proportion of negative test results out of all culture incorrect results, and the positive predictive value, the probability that subjects with a positive test truly have the disease, and negative predictive value, the probability that subjects with a negative test truly do not have the disease. The validity of the test was assessed with 95% confidence interval. In results, out of 155 isolates, 67.1, 18.7, 6.5%, and 7.57 organisms identified as cocci, bacilli, coccobacilli, and yeast respectively. The image shows microscopic appearance of the direct smears stained with toluidine blue. This table shows sensitivity, specificity, positive predictive value, and negative predictive value with 95% confidence interval of gram stain and toluidine blue compared to the gold standard culture results. In the identification of cocci, sensitivity, specificity, positive predictive value, and negative predictive value of gram stain and the toluidine blue stains were close to 100%. When detecting bacilli, sensitivity of both gram stain and toluidine blue stain was low, but positive predictive value is higher in toluidine blue stain. Specificity of both stains were high, indicating the low false positive rate. The sensitivity, specificity, positive predictive value, and negative predictive value were higher in toluidine blue stain than gram stain for the identification of coccobacilli. Yeast were precisely identified by both gram stain and the toluidine blue stain. Overall, microorganisms in direct smears stained with toluidine blue were more clearly visible as the background staining was minimal. This microscopic image shows gram stain and toluidine blue staining of direct blood culture broth. In conclusion, significant differences were not observed when identifying cocci and bacilli from direct smear of positive blood culture using both gram stain and the toluidine blue stain. However, there was a significant difference between the two stains in the identification of coccobacilli. All yeast could be identified with same effectiveness. Toluidine blue stain is useful for identifying bacteria and yeast according to their morphology in positive blood culture broths as an accurate, rapid, and cost-effective technique. However, in routine practice, identification of the microorganisms as either gram-positive or negative is very important. Staining with toluidine blue helps in the identification of different morphologies only. Thank you.
Thank you very much for your presentation. There was one question. I would like to remind all the audience to direct your questions through the Q&A section. And the question is, what are the disadvantages of toluidine blue stain?
Thank you, Madam, for your question. And regarding toluidine blue, as it is a simple stain, we won't be able to differentiate whether it is a gram positive or gram negative. That means we can't it doesn't give any differential stain to the organisms. But compared to that gram stain, being a differential stain, we can identify the organisms as gram positives and gram negatives. That's the one disadvantage of the toluidine blue, because it only gives the morphological identification of the organism.
Thank you.
I have a question to ask. Is it okay? Is it okay to ask a question?
Yes.
Yes. The gram stain and the stain, is it expensive or is it time consuming? In those aspects, can you compare these two?
Gram stain actually takes around 3 to 4 minutes to stain, and it's a little bit expensive than the toluidine blue stain. Compared to that, toluidine blue stain just take only 2 minutes to stain a smear, and also it's less expensive than the gram stain, because gram stain we have to use 3 or 4 staining regions, whereas in the toluidine blue we have to use 2 staining regions. Therefore, comparing all these things, less expensive method is the gram toluidine blue, and also it takes less time than the gram stain technique.
Thank you.
There's some more time for the questions. All right, thank you very much for your presentation. We'll move on to the next presentation. That's on prevalence of pain among institutionalized older adults in Galle district, a descriptive study by Abesekara, NWBY, and De Souza, GED. And the paper will be presented by Abesekara, NWBY.
Good evening to all of you. I'm Buddhini Abesekara from Faculty of Allied Health Sciences, and I'm going to present the findings of our research under the topic of prevalence of pain among institutionalized older adults in Galle district, a descriptive study. When we talk about the population aging, it is a significant social problem worldwide, and Sri Lanka's second line as it is. Few decades back, Sri Lankan family structure was enough to take care of their own elders. But due to the gradual changes of society and family structure compelled many elders to appeal for elderly care facilities in institutions at present. So, the number of elders who seek institutionalized care increases day by day, and they face so many problems other than to live away with their loved ones. Those problems can be financial, physiological, and psychological. Among those issues, suffering from any kind of pain due to the physical or psychological reasons take a huge part in their lives. Though these problems are common and negatively impact the quality of lives of the affected elderly, they are most neglected conditions because people consider them as the issues which emerge with the elderly life. When we talk about the pain, it is a common condition with an unpleasant sense of discomfort that persists or progress over a long period of time. And that can be due to the physiological or psychological reasons. After some time, that can become a catastrophizing belief that related to the pain. Pain catastrophizing refers to a set of exaggerated and dominating negative cognitions and emotions during actual or perceived painful stimulation. With this background, the study was designed to assess the prevalence of pain in institutionalized older adults in the Galle district. Ethical approval for the study was obtained from the Ethics Review Committee of the Faculty of Allied Health Sciences. A descriptive cross-sectional study was conducted in 20 elderly homes in Galle district, and 310 elders were enrolled in the study with their informed consents. We have used an interviewer-administered questionnaire and validated single version of pain catastrophizing scale to collect data and to assess the physical and psychological pain. Data were analyzed using SPSS version 25 for Windows, and p-value was considered as less than 0.05. Pain catastrophizing scale was a tool that is used to assess the catastrophizing pain, and it is considered as an instrument which is used to quantify the catastrophizing thinking related to pain. According to the scale, one has to indicate the degree of which they experienced each of 13 thoughts or feelings when experiencing pain. Total score of pain catastrophizing scale range from 0 to 52, and more than 20 indicates a considerable catastrophizing pain. Subscales of pain catastrophizing scale consist of rumination, magnification, and helplessness. Let's move on to the result section. As you can see here, this sample was consist with 310 elders with the mean age of 74.58 years, and about 65% of them were females. When we consider the socio-demographic characteristics of the study sample, majority of them were unmarried and 75.5% of them had a 1 to 5 year duration of institutionalized life. We have used the Mannequin of Manchester definition of chronic widespread pain to assess the physical pain. As you can see in this figure, most of the elders had limb pains other than the back pain, and 60.6% of them had pain in more than one side, and 52.3% of them got treatment for their pain. According to the results of the assessment of pain in the study sample, 78.7% of them had any kind of pain. As you can see in this chart, most of them were unable to point out the exact reason for their pain, and they were suffering from chronic psychological pain than physical pain. As you can see, according to the findings of the study, 91.9% of subjects had catastrophizing pain and 29% of them had considerable catastrophizing pain according to the pain catastrophizing scale. According to the subscales of pain catastrophizing scale, from the total subject who had catastrophizing pain, 77.7% had helplessness, 82.9% had magnification, and 83.9% had rumination. So, according to the findings of this study, we can conclude that prevalence of both physical and psychological pain is high among institutionalized older adults in the study sample. And it is very important to take measures to detect their problems early and to plan appropriate interventions to improve the quality of lives of these affected institutionalized older adults. These are some of the references that I have used for my study. Thank you all for listening to me and giving me this valuable opportunity.
Thank you very much for your valuable presentation. And now the paper is open for the discussion. Please send your questions through the Q&A box.
Congratulations on your study. You have mentioned that you measured chronic pain. I didn't see a definition saying what is the duration of this pain that you have considered to say that it's chronic.
Thank you, madam, for your question. Sorry for not mentioning that in my slides, but we have considered the chronic state as anyone has pain more than 3 months. And that it is the statement that we have used for chronic pain.
Okay.
Thank you, madam.
Any further questions, please?
There's another question. Is your findings significantly different from published data?
No, yes, madam. Yes,
Did you hear the question?
Yes, madam. The data is quite different from the previous studies. Yes, so there was a significant difference with the findings of our study and the previous studies.
The findings of your study is different from the others.
Yes, madam.
The published data.
Yes.
Any possible reason?
Madam, there were a less number of studies carried out the institutionalized elders previously. We have found some studies which were conducted in Colombo district with institutionalized elders, when comparing with those findings, there are some sort of difference with the percentages of these findings in this study, but I don't know the exact reason for that. I think institutionalized elders may suffer from pain because they are unable to express that because they are not with their loved ones, and they are always try to compensate that with their current situation, and they try to adjust with their lifestyles and ignore them. So I think because of the lack of attention, they are more prone to neglect their problems. So I think that is the reason for their significant difference in these findings.
Yeah, thank you very much. We'll move on to next paper.
We'll move on to the next presentation. The title of the presentation is Incidence of Anthracycline-Induced Cardiotoxicity in Breast Cancer Patients Admitted to Teaching Hospital, Karapitiya, authored by Sandamali J.N., Hevawasam R.P., Fernando M.A.C.S.S., Jayatilaka K.A.P.W., Madhurave R.D., Sadanandan P.P., Ekanayaka U., and Horadugoda J. The paper will be presented by Sandamali J.A.N.
Good afternoon, dear sir and madam. Topic of my study is incidence of anthracycline-induced cardiotoxicity in breast cancer patients admitted to the teaching hospital, Karapitiya. Anthracyclines are commonly used to treat wide variety of solid organ tumors and hematologic malignancies. They are among the most effective anti-cancer drugs ever developed, and interaction of them increase the survival rate from 30% to 70%. However, dose-dependent cardiotoxicity of anthracyclines compromises its clinical effectiveness. Cardiotoxicity induced in anthracycline chemotherapy can be divided as acute, subacute, and chronic cardiotoxicity. Although echocardiography is a commonly used method to identify cardiotoxicity, sometimes it is not a suitable method as it detects the abnormality after having some degree of damage to the myocardium. Therefore, selective biomarkers such as troponin and N-terminal probrain natriuretic peptide have been identified as very useful biomarkers to identify subtle changes in the heart. When considered the incidence of anthracycline-induced cardiotoxicity in Sri Lanka, studies have never been carried out. Therefore, objective of this study was to determine the incidence of anthracycline-induced acute and early onset chronic progressive cardiotoxicity in cancer patients admitted to the teaching hospital, Karapitiya. This is the methodology. Ethical approval was obtained from the Faculty of Medicine, University of Ruhuna. A prospective cohort study was performed at Teaching Hospital, Karapitiya. All newly diagnosed breast cancer patients who were administered with anthracycline and cyclophosphamide for the first time and who gave informed consent were enrolled in the study. These exclusion criteria were considered when recruiting the patients. An interviewer-administered questionnaire was used to collect the socio-demographic data and other relevant information. Any other information required was collected from the BHT and investigation reports. 196 patients were recruited to the study. Blood was collected from each patient at 4 occasions, 1 day prior to anthracycline chemotherapy, 1 day after the first dose of chemotherapy, 1 day after the last dose, and 6 months after the completion of anthracycline chemotherapy. The concentration of cardiac troponin I and the NT-proBNP were estimated. The reference value for the NT-proBNP was considered as less than 125 picogram per ml, and the positive cardiac troponin I concentration was considered as more than 0.01 nanogram per ml. However, a significant elevation was considered as more than 0.04 nanogram per ml. This is because this is the value which evidences myocardial necrosis. These are the results. When considered the baseline characteristics of patients, the mean age of the patients recruited to the study was around 53 years old, and the cumulative dose of anthracycline received was around 340 milligram per square meter. More than 51% of patients had Nottingham grade 2 cancers, and more than 80% of patients received doxorubicin as the anthracycline drug. And more than 98% of patients received 4 cycles. More than 42% of patients had diabetes mellitus, and more than 35% of patients had dyslipidemia. When compared the biochemical parameters among 4 stages, a significant difference was observed between baseline value and the 1 day after the first dose of anthracycline chemotherapy, 1 day after the last dose, and 6 months after the completion of anthracycline chemotherapy. However, none of the patients showed these biochemical parameters beyond the reference value 1 day after the first dose of anthracycline chemotherapy. There were more than 31% of patients with NT-proBNP concentration more than the reference value 1 day after the last dose, and more than 46% of patients 6 months after the completion of anthracycline chemotherapy. There were more than 10% of patients with cardiac troponin I concentration more than 0.04 nanogram per ml 1 day after last dose, and more than 41% of patients 6 months after the completion of anthracycline chemotherapy. Logistic regression analysis was performed to identify the risk factors which affect for the occurrence of cardiotoxicity. According to the univariate and multivariate analysis, cumulative dose of anthracycline more than 350 milligram per square meter was identified as the mostly affected risk factor for the occurrence of cardiotoxicity. These biochemical parameters used in this study because troponins are highly sensitive and specific cardiac biomarkers released to the circulation when there is a myocardial injury. Also, NT-proBNP is identified as a reliable marker to investigate anthracycline-induced cardiotoxicity as it correlates with left ventricular dysfunction. According to the results, cardiotoxic evidences were observed 1 day after the last dose and 6 months after the completion of anthracycline chemotherapy. However, influence of cyclophosphamide for the development of subclinical cardiotoxicity cannot be excluded as anthracycline was given only as a combination therapy. Risk factors including radiation therapy and other cardiotoxic drugs may also contribute for the development of subclinical cardiotoxicity, as this study was conducted as a prospective cohort study. According to this study, although acute cardiotoxicity was not observed in these patients, incidence of early onset chronic progressive cardiotoxicity was significantly high. Therefore, it is recommended to carry out long-term follow-up to detect the cardiotoxicity in the patients receiving anthracycline chemotherapy. These are the sum of the references. Thank you.
Thank you for your presentation, and the paper is now open for discussion.
Yeah, there's one question from Sudhira Jayasinghe. Did you compare the effect of 2 drugs, which is more cardiotoxic?
Yes, actually, I compared two drugs, but there was a problem with the number of cases because the more than 80% of patients were given doxorubicin and only 20% was given epirubicin. Anyway, with the literature, the doxorubicin is the most cardiotoxic drug. In this study, we couldn't get significant results because of this less number of cases in epirubicin.
I'd like to ask 2 questions. Congratulations on your presentation.
Thank you.
Why do you say that this is a cohort study?
Cohort study.
Were there any, to my understanding, without a comparative arm, you cannot say that it's a cohort study. And were there any missing dropouts in the study?
Yes, madam, there were dropouts, but actually I want to get 196 participants to get significant results. Therefore, when there are dropouts, I again collect data from new patients and try to finish the study with 196.
Okay, thank you.
Thank you, madam.
All right, thank you. This is the last presentation. Cardiac rhythm abnormalities among patients underwent total cavopulmonary connection completion, authored by Surya Sena, IAGP, Frammer A, Jones B. Paper will be presented by Surya Sena, IAGP.
Good morning. I'm Dr. J.G.P. Suryasen. I'm the Acting Pediatric Cardiac Research Teaching Hospital, Ratnapura, and I'm going to present one of my research works done during my foreign training at the Royal Children's Hospital, Melbourne. So this is about cardiac rhythm abnormalities among patients undergoing total cavopulmonary connection completion, or commonly referred as Fontan completion. The general objective was to describe the cardiac rhythm abnormalities and outcome in patients with physiologic ventricular hearts undergoing TCPC completion. And the specific objectives were to determine the incidence of the occurrence of arrhythmia following TCPC, to describe the outcome of arrhythmia following TCPC, to identify pre-surgery associated factors with the occurrence of arrhythmia following surgery. So this is the methodology. Ethics approval is obtained from the Royal Children's Hospital, Melbourne, Human Research Ethics Committee, and also the governance authorization was obtained from the Melbourne Children's Campus. This was a retrospective longitudinal study done on patients who underwent Fontan completion at the Royal Children's Hospital from January 2015 to September 2020, and patients were recruited by consecutive sampling, and the data was obtained from hospital records, mainly from the cardiology unit database, cardiac catheterization database, and the missing information was obtained from patient records. Statistical analysis was performed using SPSS version 25. All demographic, morphologic, operative, and postoperative variables summarized with descriptive statistics. Independent sample t-test used to identify factors associated with arrhythmia. Significance levels was considered as 5%. So there were 102 patients who underwent surgery during this study period, and out of this, 64% were male and 36% were female. And this table illustrates the underlying prominent ventricle So 53 patients had the left ventricle as the prominent ventricle, and 47 patients had the right ventricle as the prominent ventricle, and 2 had undetermined prominent ventricle. And all patients has had an extracardiac type of Fontan completion in this cohort, and majority or 93% of the patients has had a fenestrated conduit as the conduit during the surgery. So this table illustrates the underlying main diagnosis. So we can see hypoplastic left heart syndrome was the commonest underlying diagnosis, followed by tricuspid atresia, unbalanced AVST, pulmonary atresia with intact ventricular septum. So this is the age distribution. We understand that majority of the patient cohort is within 2 to 6 years age group. So out of these 102 patients, 25 patients developed arrhythmia following surgery. So the incidence of arrhythmia was 24.5%. So out of these 25 patients, 13 had tachyarrhythmia, whereas bradyarrhythmia was less common. And supraventricular tachycardia was the commonest type of tachyarrhythmia. And the bradyarrhythmias was characterized by AV block, junctional bradycardias, and nodal bradycardias. And out of these 25 patients, 15 patients has developed the arrhythmia during their initial cardiac ICU stay, and 3 patients has developed arrhythmia during the cardiac ward stay, and 4 patients developed arrhythmia after discharge from hospital. And this is the time of arrhythmia occurrence. We see more than half of the patients has developed arrhythmia on the day 1 following surgery. And this chart illustrates the predictability of preoperative factors on occurrence of arrhythmia. So here, none of these variables, gender, predominant ventricle, or main diagnosis, is predictable of occurrence of arrhythmia following surgery. And here, the pulmonary artery pressure or the atrial pressure, both of which were measured during the pre-procedure cardiac catheterization, was not predictive of occurrence of arrhythmia. However, interestingly, the cardiac bypass duration and the aortic cross clamp duration was significantly predictive of occurrence of arrhythmia following surgery. So the mean follow-up duration for the patient cohort was 28.6 weeks. And out of this, 71% of the patients were free from arrhythmia at the last clinic visit. 5 patients has required permanent pacing, and 5 patients has ended up with Fontan failure, and there have been 3 mortalities. So this table illustrates the association between occurrence of arrhythmia and death. So those who had arrhythmia, the mortality rate was 7.7%, whereas it was 1.4% in those who didn't have a arrhythmia. So arrhythmia has a significant association with occurrence of death. So the conclusion is longer cardiopulmonary bypass duration and cross-clamp durations predict high arrhythmia burden following TCPC completion. Postoperative arrhythmias are associated with high post-procedure mortality. Thank you. These are my references.
Okay, thank you. And now the paper is open for discussion. Please direct your questions through Q&A box.
May I ask the question? Thank you for your presentation. Just would like to know what's the dropout rate.
So this was a retrospective study. So we have enrolled all the consecutive patients. There were 102 patients who underwent Fontan surgery from 2015 to 2020. And so when we recruited each and every patient during the study period.
Any further questions? Then thank you very much. And I would like to thank all the authors and presenters and the audience as well. And this will conclude our first session of this meeting. Thank you.